Good evening, students. Please confirm if the audio video is fine. In today's MDS 360-degree session for oral surgery, we will be having a look at a small topic known as biopsy. Alright, it's a small topic, so we'll quickly cover this in the next 60 minutes. Okay. So basically, what is biopsy? Biopsy is the removal of tissues from living organism for the purpose of microscopic, that is histopathological examination and diagnosis. Okay. So you use a living tissue. Okay, and it is the gold standard. Because once a diagnosis has been established on biopsy, then that is the final diagnosis. That is considered as the final diagnosis. That's why whether to differentiate between any lesion, to identify a lesion, biopsy is considered the gold standard. Okay. Now, what are the indications for biopsy? So, any lesion which is present more than a duration of 2 weeks, any lesion present for a duration of more than 2 weeks, you have to do a biopsy. You have to biopsy it to identify its nature. Lesions which do not respond to routine clinical management for 14 days or 2 weeks. So in case if you've tried to manage the lesion clinically, symptomatically, by administering certain medications or by topical application, if the lesion does not subside, you have to do a biopsy for such a lesion. The third indication is any persistent swelling. So if there is any swelling, alright, which you can either see the swelling or you can palpate the swelling, but the overlying skin or mucosa seems normal. So any persistent swelling with normal overlying tissue is an indication for biopsy. Now, lesions that are suggestive of malignancy or pre-malignant lesions. To identify a malignancy or to identify if a pre-malignant lesion has turned malignant. Okay. Intra-bony lesions which appear to be enlarging. So, intra-bony lesions, especially the ones which have confusing radiographic characteristics, such lesions also need to be biopsied. And lesions which are of extreme concern for the patient. If the lesion is giving too much anxiety to the patient, if the patient wants a biopsy, or if the patient is fearful of the word carcinoma or malignancy, and the patient is under too much of stress regarding a lesion, then also you can discuss with the patient, arrive at a decision and go ahead with biopsy. Now, we had said that lesions which give or point towards malignancy or which have characteristics of malignancy or which are suspicious for malignancy. So, which are those lesions? Lesions that bleed on gentle manipulation or touch. Alright, so a bleeding lesion is an indication for biopsy. According to the duration, this we have already seen if a lesion is beyond 2 weeks of duration. Erythroplasia. Alright, so if it is a red lesion or a red and white speckled lesion, such lesions have higher chances to transform into a malignancy, or they have high risk of malignant transformation. They also need to be biopsied. Fixation. So if a lesion is attached to its adjacent structures or surrounding tissues, that means if a lesion is fixed, if a swelling is fixed, if the swelling is not mobile, then also you have to think in terms of malignancy and biopsy the lesion. Growth rate. Suppose if the lesion is very rapidly growing. So if the patient comes to you, 2 weeks back it was about 1 centimeter, now it is around 16-17 days, it is more than 3 centimeters, more than 5 centimeters. So a rapidly growing lesion also needs to be biopsied. In duration, lesion and the surrounding tissues are firm and hard to touch. So that is induration. So if a lesion is associated with induration, that also raises a suspicion of malignancy. Such lesions also need to be biopsied. Now, your histopathological investigations are divided into biopsy and cytology. Under biopsy, we have incisional biopsy, excisional biopsy, and needle biopsy. Under incisional biopsy, we have punch and wedge biopsy. Under needle biopsy, we have something known as core needle biopsy, which is your true cut biopsy, which is further of three types: vacuum assisted, CT or image guided, or USG, that is ultrasonography guided. Under cytology, we have exfoliative cytology, brush biopsy, needle biopsy. Needle biopsy is further known as FNAC, that is fine needle aspiration cytology. You can make a note of this: fine needle aspiration cytology. And this brush biopsy over here, many authors mention this as brush biopsy, but this is actually brush cytology. All right, the correct term is brush cytology. Okay. Now the first, we'll have a look at incision biopsy. So in incision biopsy, you do not remove the entire lesion. You remove a part of the lesion along with some part of normal adjacent tissue. All right, that is what is known as incision biopsy, and this is done for comparison. This is done to differentiate the pathology from the normal tissue. All right. So incision biopsy, where is it indicated? It is done for large diffuse lesions more than 2 centimeter in its maximum dimension. So this has been asked previously. So any lesion above 2 centimeters, you'll do a incisional biopsy. You do a incisional biopsy for lesions with suspected malignant potential. Incision biopsy is minimally invasive and generally very safe. So the types of incision biopsy are: one is wedge biopsy and the second one is punch biopsy. Okay, let's have a look at wedge biopsy first. So in wedge biopsy, you remove a wedge shaped tissue. When you remove a wedge shaped tissue, it contains your lesion, the lesional tissue, as well as your normal tissue. Okay, so you give an elliptical incision. We will see this in the next slide, where I have included a visual. Okay, and a large wedge biopsy may require a two-lead closure. So in case if you've taken a larger chunk of tissue, you have gone deeper as per the depth into the normal tissue, then you might have to do the lead closure. That means you have to first close the deeper tissue, first suture the deeper tissue, and then the superficial tissue. All right. Now the indications for wedge biopsy are vesicular or bullous lesions and ulcerative lesions. All right. These two are your indications for a wedge biopsy. Now let us see what is a wedge biopsy. Okay. So here this is your lesional tissue, the one that I'm outlining in orange. Okay, and this is your normal tissue. The surrounding tissue, which I'm shading in blue, is your normal tissue. All right. So your first step is to give field or block anesthesia to anesthetize the area, to numb the area, so that the patient does not have any pain perception. Next, what you do is, please follow my pen, you give a elliptical incision. All right, you give an elliptical incision. So this contains the lesional tissue. All right, and this elliptical incision also contains the normal tissue. All right, and after this you close along the incision. So this is how your closure is done. Okay, this is how you close the incision. Now the next part is the wedge. In the previous slide we saw the visual from the top. Now I am showing you the visual in a cut section or cross section. All right, so when you are harvesting this tissue for biopsy, you should always harvest in a wedge. Okay, Now, what should be the nature of your wedge? It should be narrow and deep. Alright, it should be narrow and deep. Alright, why narrow? Because this is your lesion and this is your normal tissue. So that you can include your normal tissue. That's why your wedge has to be narrow and deep. In case it is shallow and wider, you will miss out on your normal tissue and you will not be able to include normal tissue for comparison, and you will not be probably able to arrive at the correct conclusion after doing the histopathological examination. Alright, now let us see the next type of biopsy. Under incisional biopsy, we have something known as the punch biopsy. Now this is a minimally invasive biopsy. So what is done? A small cylindrical punch is applied into the lesion through full thickness of the skin and a plug of tissue is removed. I'll just show you the visual also, and it is widely used for diagnosing skin biopsies or removing smaller lesions. Okay. So now this is how a punch biopsy looks. You can see the visual on your screen. Now punch is a small pen-like cylindrical instrument. Alright. So what happens is you have to rotate the punch and then harvest your tissue. So what is done is, once you rotate this pen from here, what happens is a small cylinder jets out here. Alright. This is a sharp hollow cylinder which when goes inside the tissue, and once you rotate it, this hollow cylinder paves its ways into the tissue. Alright. Catches hold of the tissue, and once you rotate it back, it comes out. This cylinder is retracted back once you withdraw the punch, and it comes out with your tissue. So the hollow cylinder inside is holding your tissue plug. Alright, this is how it is used. You can see the function being done over here with the hands. You can see the arrows and the hands rotating the punch. So that is your punch biopsy. Okay. Now, what are the indications of punch biopsy? It is indicated for many flat lesions. Right. Interpretation of skin tumors such as basal cell carcinomas and Kaposi sarcomas. Diagnosis of bullous lesions like pemphigus vulgaris. Diagnosis of inflammatory skin disorders like discoid lupus erythematosus. Removal of small skin lesions such as intradermal nevi, and used to confirm or exclude the presence of malignancy. So these are your indications of punch biopsy. You can put to use your punch over here in such conditions. Now, what are the advantages of punch? It is a simple procedure, easy technique. Anyone can do it. It is very easy to learn, very quick technique. You just have to use an instrument. You don't have to give any incision. Closure may also not be required unless you have gone very deep inside the tissue. Usually you do not require to do any suturing after you do a punch biopsy. It is time conserving. Alright. It has low incidence of infection, bleeding or non-healing because you're just harvesting a punch of tissue. No incision, no suturing, nothing. Scarring is insignificant, hence it is cosmetic also. So the punch is very small. Okay, the punch is very small. It leaves minimal scarring. Okay, so these are the advantages of your punch biopsy. Now, that is all we had for incision biopsy. Now we'll go on to see what is excision biopsy. Now, as the name suggests, excision means entire lesion is removed for examination and diagnosis. Please understand, I'll explain again. In incision biopsy, you are removing a part of the lesion along with adjacent normal mucosa or a normal tissue for comparison. In excisional biopsy, you are removing the complete lesion. So this becomes diagnostic also, and this becomes therapeutic or curative also, because you have removed the entire lesion. Alright. So it's diagnostic as well as curative. Indications. Important, this is done for lesions less than 2 centimeter in size and indicated for lesions which are diagnosed or seem benign and require complete removal. So you actually cannot do an excisional biopsy for a lesion which is looking suspicious for carcinoma or malignancy. You can only carry out an excisional biopsy for a benign looking lesion, alright, or a lesion which does not hold potential of being malignant. Okay. Now the advantages. Since you have removed the entire lesion, your entire tissue is available to you for histopathological examination, so there is no chance of missing out on any diagnosis. You have the entire thing with you to examine and arrive at a diagnosis. Now there are certain disadvantages of excisional biopsy. Okay, what are the disadvantages? The disadvantage is that what you have seen with the naked eye as the lesional tissue, you have removed that. But what if the lesion was a highly infiltrative tissue and at the microscopic level and beneath the surface it has infiltrated the adjacent normal areas, but which you cannot see with naked eye. Alright. Another disadvantage is, what if the lesion turns out to be malignant? So you will have to come back and do another surgery to clear off the malignancy. Third scenario may be you may leave behind residual carcinoma cells, residual malignant cells by just doing a biopsy, by doing an excisional biopsy based on what you're seeing with naked eyes. So these are certain disadvantages of excisional biopsy. So if the tumor is highly infiltrated, the margin of excision cannot be exactly elicited. Further surgery will be needed. Residual cancer cells may be left behind, and excision needs greater precision and skill of a surgeon because you have to remove the tissue, the lesion in toto. Now just look at this visual. So in the middle you see a lesion. So you take a safety margin and then give your incision and do the excisional biopsy. Okay. Now at the microscopic level, what if the tumor is infiltrating? It is a highly infiltrative tumor or it is a malignant tumor. What if it has submucosal or beneath the skin, in spite of the surface looking normal, it has spread? So this is where your excisional biopsy carries a huge disadvantage in terms of that your clearance will not be proper. Okay. That was about your excisional biopsy. Now we have something known as needle biopsy, alright, which is also known as true cut biopsy, core needle biopsy or true cut biopsy. So in this, what you do, you remove a core of tissue with the help of a needle. Alright, that needle is known as a true cut needle. I'll show you the visual for this also. So you remove a core of deep tissue using a true cut needle. This is a specialized type of needle which we'll see further into the session. Now the advantage is it allows for accurate diagnosis and large quantity of tissues can be obtained. Okay. The type and grade of tumor, its invasiveness as well as hormone receptor status can be assessed. So when you do a core biopsy, you can assess many parameters, and hormone receptor status, especially in cases of breast cancer, you can assess with the help of a true cut biopsy or a core needle biopsy. So here you see the needle for a true cut. I'll just zoom out. So if you see, this needle has a slot over here. Alright. So once this needle goes into the tissue, this slot engages the tissue that has to be removed. So this needle goes deep inside the tissue. This slot engages the tissue, and once you're withdrawing it, this slot gets the tissue along with it. Alright. That is what is done with the help of a true cut biopsy. Again, minimally invasive. So now there are different types of true cut biopsies. The first one is vacuum assisted. All right, vacuum assisted. So it is a variant of true cut or core biopsy. So the needle is attached with a suction device, an automated suction device. So that suction device, once the tissue is engaged into the needle, it creates a suction pressure. So with the help of suction pressure, you can harvest more cells and more tissues into your true cut needle. Okay, and it increases the amount of fluid and cells aspirated through the needle. It ensures a larger sample, and it reduces the need for repuncture. So with vacuum assisted, it prevents or it saves you another chance of going inside and harvesting the tissue again, because in one go it harvests a larger amount of tissue. Okay, now the second type of core biopsy or true cut biopsy that we have is image or CT guided or US guided biopsy. Now I'll just explain this in short and then we'll read through this. So what is done in a image guided, CT guided or US guided true cut biopsy is that first what is done is, with the help of imaging, either with help of a CT scan machine or with help of ultrasonography, you localize the tumor. Alright, you localize the lesion, the tumor first on via image guidance, and once you have localized exactly where the lesional tissue or tumor tissue is present, then you guide your needle exactly in that particular depth or in that particular space, so that you can harvest a accurate sample. All right, now so this is conducted with a larger needle with assisted CT scan or USG equipment, like I told you. The simultaneous scan allows identification and visualization of the exact site of the tumor on the computer screen. This also I just now explained. And this advanced technology enables the operator to directly guide the needle into the tumor and obtain several samples of tissue. So basically, what is image guiding helping you in? It is helping you in precision. It is helping you to reach your site of interest accurately. All right. Now the next thing that we have is cytology. Biopsy part is over. The next thing that we have is cytology. Cytology generally falls under pathology perspective, but there are certain things in cytology that we need to know with regards to the oral region. All right, so we'll just quickly have a look. We'll quickly go through cytology. So cytology is defined as examination of cells. Okay, the basic difference is, in biopsy you were examining a tissue harvested from a living organism, okay, and you were studying that tissue. In cytology, you do not harvest a tissue per se, you study the cells. You will understand further into the session how are we harvesting the cells and how are we studying those cells. Okay, so in cytology, what is done? The basic of cytology is a sterile wooden spatula or plastic spatula is used to scrape superficial mucosal lesion by a single powerful stroke. So you take a spatula. Let's talk about oral mucosa. You take a plastic or a wooden spatula. Suppose there is a lesion, all right, you scrape the lesion with a powerful stroke, so that, and with some pressure, so that you go to a bit of depth also. Now once you have scraped that your region or area of interest, you smear whatever you have scraped onto a slide. You prepare a smear. Okay, and that slide you study under a microscope. So this is how a cytology study is carried out. You have not harvested a tissue, you have collected cells from your area of interest. So the collected material is placed on a glass slide and a thin smear is made. The collected cells are then fixed using absolute alcohol or standard fixatives, after which you will study them under a microscope. So where does cytology come into play? It is suitable for diagnosis of herpes simplex infections, herpes zoster infections, pemphigus vulgaris and white sponge nevus. Okay. Now, how is a exfoliative cytology reporting done? So you are now just studying the cells. You will report in terms of what type of cells you will see. Okay. Whenever you do an exfoliative cytology, you will be able to differentiate the morphology of the cells, whether these are inflammatory cells, whether they are malignant cells, whether they are atypical cells, or whether they are normal cells. So your reporting is done based on classes. So class 1 is normal. It's a normal cytological study. That means you see normal cells. Class 2 is atypical. It indicates the presence of minor atypia but no evidence of malignant changes. That is your class 2. Class 3 is intermediate. Now, what is intermediate? That they are somewhere in between cancer cells and normal cells. So there is something that cannot be completely differentiated, but they are somewhere in between. So you recommend a biopsy for such a situation. So biopsy is recommended to identify the exact nature of the pathology. In class 4, it is reported as suggestive of cancer. So when is it reported as suggestive of cancer? When you can see a few cancer cells and when you can see a few cells which are showing dysplastic or borderline cancer-like changes. So there you cannot completely say that all of them are malignant. Few may be and few may be borderline malignant. So suggestive of. Okay. That is why biopsy becomes mandatory here. Biopsy becomes mandatory in class 4. Now class 5, where you can see the cells are positive for cancer. You can see frank malignant cells where malignant transformation has taken place, and now you will tell the clinician that please go ahead, biopsy this and identify the exact nature of your cancer cells. So cells are malignant and biopsy is again mandatory. Okay, that was your exfoliative cytology. Now we have something known as brush cytology. Okay, brush cytology. This is also called as brush biopsy by many people, but that is not the correct terminology. The correct terminology is brush cytology. So in brush cytology, you actually use a brush to collect cells, alright, for cytological study. So cytology specimen is taken with help of a cytology brush. The brush should be rotated 5 to 10 times over the suspicious lesion with firm pressure to take cells from superficial as well as deeper layers. I'll just show you the visual also. So cytology brushes are available. Cytology kits are available, brush cytology kits which carry brushes, and you have to use that brush with firm pressure and you have to harvest cells from the superficial as well as deep layers. Alright, and like I told you, it is wrongly mentioned as brush biopsy by some authors. So what are the indications? The indications are monitoring patients with chronic mucosal changes, for example leukoplakia, lichen planus and irradiation damage, and for surveillance of patients with history of oral cancer. Now what do you mean? Suppose there is a pre-malignant lesion or pre-malignant condition, alright, and you want to study it, you want to rule out whether any transformation has taken place. So in that pre-malignant or precancerous lesion, you can use a brush biopsy. One. Second, if the patient has had prior history of oral cancer and now is on follow-up with you, but sometimes you may see some small mucosal change in the patient's oral cavity. So for that mucosal change, before going in for a biopsy, you can do a brush cytology to determine the exact nature of the mucosal change that has taken place in a patient with prior history of oral cancer. Okay. So just have a look at this visual over here. So this is a oral brush cytology which is taking place out here. Okay. What is being done is, if you see that brush, you apply the brush to the oral mucosa with a little firm pressure, alright, so that it can harvest deeper cells and superficial cells from all around. This is your brush cytology, and the brush should actually be rotated for 5 to 10 times so that you get a good amount of cells to prepare your cytological smear. Now this is important. There is a particular system that is available for oral brush cytology which is known as oral CDX. Oral CDX. Okay. This is a diagnostic system which combines a painless oral brush biopsy. It collects full transepithelial tissue which is taken and in the dental office, and it combines it with advanced computer analysis. So basically oral CDX is your brush cytology and a computer analysis. Okay. Now how is the interpretation of a specimen done for oral CDX? So the first thing is negative. That means everything is normal, there is no epithelial abnormality, the cells are normal. Atypical. Second one is atypical. So abnormal epithelial changes, but they are of uncertain diagnostic significance. Okay. Positive. Definitive evidence of dysplasia or carcinoma. And inadequate, that means you have not collected a good sample. These cells that need to be examined are inadequate and no study can be carried out on them. So incomplete transepithelial biopsy. So your brush biopsy is important. Questions can be asked from here. Okay. The next thing we have under cytology is fine needle aspiration cytology. Students, please don't confuse. There is something known as needle biopsy and fine needle aspiration cytology. In needle biopsy, we saw a true cut needle where the needle is harvesting a core of tissue. Okay. However, in fine needle aspiration cytology, we are just harvesting the cells with the help of a needle. Okay. So in this method of cytology, a fine needle is used to take cells for microscopic examination. Okay. The indications are a deep-seated lesion where you cannot reach, where access is an issue, deep-seated lesions. Major salivary gland lesions. Okay. And central bony lesions. Fine. These are the indications of FNAC. Now the needle size, what you use a 18 gauge needle. Some authors also prefer a 16 gauge needle, but please always give preference to 18/16 when you are marking your answer. This is important. This point is important. Okay. Just have a look. This is how an aspiration is done. So you go. This is a cystic lesion. You introduce your needle, you aspirate the cystic contents, and along with the cystic contents, you'll get your cells also. You will prepare a smear and you will study the nature of the lesion. Now, one more thing, that you can do with this FNAC is to differentiate whether it's a cystic lesion or a solid lesion. So solid lesion will may give you few cells, cystic lesion will give you the cystic fluid also. Okay, so this is how an FNAC is done. So what are the advantages? It differentiates between a vascular and non-vascular lesion. So in case if you do a FNAC and you get blood in your needle, that means the lesion is vascular in nature. Then you have to be very careful while addressing such kind of lesion. It can be a high flow lesion. Okay. It can also tell you about whether it is solid or cystic, which I just now explained you. Okay. Now this is how a FNAC is done for a thyroid swelling. Here you see that a needle is pointed at the thyroid gland. Okay. So under USG guidance, because with just by looking at the patient, you cannot find out where the thyroid exactly is, where to aim your needle. Okay. You use a ultrasound probe, USG probe, to localize the thyroid and the swelling present in the thyroid. Then you introduce a needle to do a FNAC. You collect those cells, send it for cytology, and then they'll give you back the report regarding the nature of the lesion. Alright. With that, our biopsy and cytology are over. There are actually 2-3 things which are important, which may have the potential to be asked. Alright, so we need to know them. Now the first thing is when to do a repeat biopsy. So you will do a repeat biopsy in 2 scenarios. First one is when you looking at the lesion seems very suspicious. Okay, but looking at the lesion, it gives you a feeling that it may be something very aggressive, malignant. But when the biopsy has reported it something, maybe say as an inflammatory lesion or something else which does not correlate, so your clinical features and the report that you have got for your biopsy does not correlate, they somehow don't match, and you are not very convinced with your biopsy report. In that cases, you go in for a repeat biopsy. If there is marked conflict between the clinical and histopathological diagnosis, it is best to repeat the biopsy. Alright, and if you have an inconclusive biopsy, in case you feel that this lesion is highly suspicious for a malignancy and the reporting has come back as inconclusive or inadequate sample, or pathology could not be assessed due to insufficient tissue, then you again have to repeat your biopsy. Okay. Now there's something known as a sentinel node biopsy. You don't need to go into the details. This is actually a postgraduate level concept, but just to give you an idea in case a question is asked. Now what is a sentinel node? Sentinel node is the first lymph node where your cancer cells have spread. That is known as your sentinel lymph node. What is done in a sentinel lymph node biopsy? Let's see, we will take an example of oral cancer. Alright, suppose there is a lesion, alright, in the oral cavity. You have planned its surgery, okay, and you also want to do a neck dissection, but you want to do a conservative neck dissection. All right, you want to only remove those neck nodes to which the cancer cells have spread. So what you do is you take a blue dye, usually you take methylene blue, you inject around your tumor area, wait for few minutes, the dye will flow along the lymphatics, especially to those lymph nodes where the cancer has spread. So what is done is you have a specialized camera to view the flow of the dye. Where is it going, whether it's being taken up by a node or not. So the node, that if you see a node which is taken up the dye, which is showing uptake of the dye on your specialized camera, you just give an incision over that node and remove that particular node, instead of doing levels of neck dissection. Instead of removing all the lymph nodes in the neck, you just remove the nodes which have taken up the dye and which show migration of cancer cells or infiltration of cancer cells. That is your sentinel lymph node biopsy. Okay, so we'll just have a look. Just a moment, just give me 2 minutes. Yes, so sorry for the interruption. So we were talking about sentinel lymph node biopsy, right? So I had just explained you the technique. We'll just go through it. A sentinel lymph node biopsy is a procedure in which sentinel lymph node is identified, removed and examined to determine whether cancer cells are present or not. It is done by injecting a blue dye, usually methylene blue, near the tumor to locate the position of the sentinel lymph node. So basically to localize the lymph node. Once the sentinel node is located, surgeon makes a small incision about half an inch on the overlying skin and removes the particular node which has been infiltrated by cancer cells, and this prevents extensive lymph node dissection. So this is an advantage. You just need to remember this much. Okay. Now the last part of our session, after that we wind up, there's something known as a frozen section. Frozen section biopsy. Now this biopsy is used intraoperatively. Now when is it used? Let's say, for example, this is our lesion, alright, what I'm shading in orange, and this is the normal tissue surrounding it. Okay. Now when you are doing the resection, you will take a safety margin of 1 to 1.5 all around this. Okay. Now you want to be sure of your margins before completing your surgery. You want to be sure whether the safety margins you have taken, they are clear of cancer cells or not. So you send this to the pathologist from within the OT. You send this to the pathologist. Alright. The pathologist processes the sample and gives you back the report in half an hour. So what they do is they cool down the sample to a few hundreds of minus temperatures. Alright. And then this sample is incorporated onto a gel. Serial sections are made, they are cut into very fine sections and the margins are studied. Okay. So now two things can happen. The pathologist can tell you all margins are free of tumor. That means you have done a good clearance. Okay. Now suppose if the pathologist tells you inferior margin is close or is infiltrated by the tumor, then what you do is you will take a little more inferior tissue. Once the pathologist tells you inferior margin seems little close or tumor cells seem infiltrating the inferior margin, you will go and re-revise your margin. You will remove extra tissue from the inferior margin so that you get a good clearance. Alright, this is how a frozen section helps you intraoperatively. It does not define the nature of the disease. It does not tell you details of the disease. It just tells you or gives you clarity on your margins, whether you have done a good clearance, your resected margins are free of tumor cells or not. All right. So to ensure surgical margins of resection are clear, free of tumor, the tissue is loaded onto a metallic cassette, stabilized and rapidly frozen to -20 to -300 degrees Celsius. Okay. And report is available within a few minutes, especially in half an hour time. So once it is loaded onto this cassette, it is incorporated into a gel-like material, and those blocks are cut into thin sections to study your margins. All right. So with that, your chapter for biopsy is over. If there are any doubts, you can ask me in the comment section below. And I leave you with the schedule for the upcoming week for the MDS 360-degree series. Okay. Thank you for joining in, students. Good night.